Hypotension. So we're back to treating orthostatic hypotension, which is always problematic and challenging. They may require an ICD. Very often, they may develop atrial fibrillation due to changes in the left atrial structures, and therefore we got to consider anticoagulation. And I would say very rarely do we get down to the concept of transplantation. And usually doing a transplant does not solve the problem, unfortunately. So that's something. So what can we do? Well, this is where it gets really interesting, and I think this is where the science has really expanded in the last several years. First of all, I'm going to talk specifically about transthyroidamyloidosis. First, we could suppress its synthesis. So liver transplant is one option, but again, it might still involve other pathways to create that, so that might not do it. But you can also use what's called transthyretin gene silencers, and I'll come back to that, where we actually reduce the production from the liver of these tetramers, which then can cause problems. Now, when the tetramers are formed, that's not the problem. The problem is they dissociate and they start to fragment and form those fibrils. So if we could stabilize them with a variety of agents, and what you may have heard about is tafamidis, which is currently on the market now for use in this disorder. But there are other agents, including AG10, that's in clinical studies. And yes, green tea is actually on there. I'm not sure of the data, there's not much, but some people are talking about it as having some major properties that are useful. And then if we go down the line here, now we form amyloid fibrils, but sometimes we can actually disrupt that fibril and cause resorption. And our good friend doxycycline may actually be something to consider in the future. Now, since it's a very inexpensive drug off patent, there's not a lot of funding for that kind of trial right now, but it's still very intriguing, and there are the development of monoclonals that potentially will remove those fibrils. So first of all, we can stop the synthesis, we can stabilize the tetramer, or we can try to remove the fibrils. Now, silencing is very interesting. This gets into the molecular biology a little bit beyond my knowledge base, but very, very interesting here. So if we look at the cell membrane here, we can induce through this mRNA silencer, it comes in here and actually shuts down the process so that instead of the encoding from the nucleus of the mRNA to create these fibrils, it's actually disrupted. So we're silencing the production of the tetramer, in this case with patisiran, which is actually approved now for use of polyneuropathies associated with amyloidosis. So it hasn't been shown in the cardiac sphere, but it's been shown very effectively in the neurologic sphere, and there are ongoing clinical trials with this agent and others. And there's also intericin, which is another agent. Again, it's using antisense oligonucleotides to once again disrupt this and bind to the mRNA, causing it to be destroyed, and therefore the production of protein, in this case the TTR, is not done. So these are two rather high-tech approaches. They're in clinical trials right now for cardiac amyloidosis. This is another one also that potentially has applications for neurology also. So this is a summary of this issue. Patisiran is used as IV infusions every 3 weeks. It has been shown to be efficacious in neuropathies, and there's some preliminary data that it's also working effectively on the cardiac area. That's not a typo. That is the cost, $414,000 per year. It's rather remarkable. So I think we want to have a firm diagnosis, and there's a lot of discussions of who and what are going to pay for that. And intericin, which is actually just being released now, again at about $360,000, has also shown to be efficacious in neurology and in cardiac areas related to amyloidosis. In this case, it's a weekly injection, so maybe not as useful, maybe not as comfortable to do. So these are very intensive therapies. Then we get into the stabilization of the tetramer so it doesn't dissociate and form fibrils. I won't go to diflucanol, but I will talk about tafamidis, which now has a number of different things. You've probably picked up a journal in the last week or so and seen ads for this product. It's everywhere now, and it's being marketed very heavily. It's a once daily pill, a lot easier than infusions or injections. It has been shown, and I'll show you slides, that it's very efficacious, not just in terms of symptom reduction, but especially for cardiovascular morbidity and mortality. The price, however, again, $250,000 a year. And this is now available. And people are on it, and people are getting this. And actually some insurance companies are actually paying for this, which is quite remarkable. So this is the tafamidis data from Matthew Maurer, showing that if you look at the months since the first time they were dosed, you can see that the curves start to split from placebo to tafamidis. And this was a study done in over 400 patients that had class 1 to class 3 New York Heart Failure Association, and it looked at bodies. It looked at all-cause mortality. So this is having a benefit in terms of survival. Now, there were also some secondary endpoints beyond just surviving, and these are those. This is the 6-minute walk test. The tafamidis group did much better, and changes in the baseline quality of life, again, was in favor of tafamidis. So at least in the short term, over the course of the first 2 years, it looks like it's saving lives and improving the quality of life in patients with TTR cardiomyopathy. So this is the first time we've seen this drug. As I mentioned, there's other agents that are now in development. But this sort of changes the whole paradigm. First, we hear about the disease. Now we learned how to diagnose it. Now we realize it's pretty common. And now we've got some real treatments which are completely different than anything we've ever seen before. Now, I want to emphasize this part. This is really important. We need to be screening and looking for this because, as you know, right now we may argue about the prices and whether that price will come down or what we can do, but at least recognizing that this is a problem, and especially for people with the genetic mutations. So clearly, very highly prevalent in patients with heart failure with preserved ejection fractions. Here in the New Orleans area, we have to consider African Americans that come in with any sort of symptoms suggestive of this, and especially in the setting of a polyneuropathy or unexplained heart failure with preserved ejection fraction. Now, there's some very sort of minor tests. These don't really help us. The NT-proBNP or the troponins are markers. Maybe something's going on, we don't really understand it, but they're clearly not diagnostic. There may be a test in the future, but I think right now as well we have a really good diagnostic studies with the imaging studies that we can use. Now, if we suspect someone, and especially in the African American population, importantly, we can actually find out, do they have the genetic mutation? Now, normally, most of these companies provide the services. Some of them you may recognize as doing this. The cost of the genetic testing of the individual and potentially of the family members, because this is an autosomal dominant disease. So if the mutation's there, it's very likely that offspring are going to have it. Fortunately, through ACT, you can actually do this for free. They will sponsor the test, and you can send it off. There are forms, and you can get the genetic sequencing, and they'll look for all of those classic mutations that might be associated with TTR amyloidosis. So I think that's a wonderful program. I think we're going to see a lot more. So if it's 4% of our population, that's a pretty significant number. Now, if we're doing genetic screening, and if we're looking at the genomes for these patients, we have to incorporate genetic counseling. So basically, as I mentioned, anyone who has transthyretin cardiomyopathy needs to consider whether there's an impact on the family. So we want to consider, is there a genetic mutation? So that perhaps we elevate diagnosis and then treatment, especially for those first-degree relatives that are really at risk. We want to educate the patient, and this is beyond what most of us do. Certainly, I don't know how to do that. So really, a genetics counselor is really key. This can be done by telephone, sometimes in person, but if we're going to start to adopt the concept of genetic testing and looking at patients at risk, we have to include the counseling. I want to just conclude that we're actually very interested in this at Tulane. A few months ago, we've established the Tulane Amyloidosis Center, and this is truly a multi-organ disease, and it's one of the few things that, I as a cardiologist, I get to sort of enjoy the participation of other specialties, and it involves all of these organ systems. So we've tried to put people together to try to form, an understanding of this and look for polyneuropathies even in the setting of cardiomyopathy or vice versa. Digestive disorders, renal AKIs and CKDs are all wrapped into this whole thing. So we've developed the center, and we're starting to move forward with this, and we've got a large support staff. And I think importantly, as you might expect, we're also starting a number of research studies. In this case, partisiran, vutrisiran, and this is the tyrosine agent. So we have 3 agents that we're actually using, in addition to the FDA-approved tafamidis, which is out there. So I hope in the last half an hour or so I've given you at least something to think about a disease you probably haven't heard very much about it in the last few years, but suddenly it's now in all our journals, we're talking about it, and we have excellent diagnostic tools, and now some real excitement about therapeutics. And again, I don't want to get into the issues of the finances, because I think right now first we have to adopt the idea that maybe this is a beneficial treatment. And I think it's still early. I don't think every person with this disease needs to be on $500,000 therapy, but it's something to at least start to look at, and I think it's an exciting area. So, in conclusion, I think cardiac amyloidosis is a very not uncommon disease that's rapidly progressive and certainly life-threatening. I think the key is not to overlook. So all of you who are doing primary care or seeing patients, that may come in with vague symptoms, and we've got to think about it. Early detection really may lead to appropriate care and have an impact. Imaging, I think, is the cornerstone of this, as I've highlighted: echo, MR, and especially scintigraphy. And usually we don't need invasive procedures like biopsies. We want to try to figure out what type of cardiac amyloidosis is, and this may require histochemistry or other things if we do have to do a biopsy. Genetic testing, especially for first-degree relatives and TTR, is really recommended. And I think we're now starting to see the development of effective therapies, both for light chain as well as transthyroidamyloidosis, using different approaches. So I want to thank you very much for your attention, and I hope you agree that it's not the zero anymore. Thanks. Yes, sir.
I'm familiar with the PYP scan and the pre-chain assay. I'm not familiar with the serum and urine immunofixation.
Yeah, the immunofixation.
What are they, and do they add much to the pre-chain pre-chain assay?
It does, because the free chain, the free serum light chains may be normal, and you're going to see this bump in immunofixation. So it's still very important to look at urine and serum immunofixation. So but they sort of wrap
That's
up.
not a SPEP.
No, it's not SPEP. SPEP is diagnostically nowhere near as accurate.
It's not an area of expertise for me. So are those tests generally,
yes.
run urine and serum?
It's a great question. Yes, almost all pathology labs can do it or have access to it. Yes, sir.
Question about that laundry list of associated non-cardiac symptoms.
Yes.
What's the timing on that? Is that any time in the patient's life, or is it during the amyloid process?
It's part of the process. So again, some of the genetic variants, and especially if it's light chain or the wild type or the mutant type, they can start occurring symptoms might occur at age 30, 40, maybe vague, fatigue, unexplained, and then if you do an echo or you do something else, you start to get some ideas of develop neuropathies. I recently had one of my administrative associates. She developed bilateral carpal tunnel. She's not typing that much, I can attest to that. And she developed bilateral carpal tunnel, and she's got amyloid. So, and which is unusual because it's usually a male prevalent disease.
We see so many elderly African-American patients with diabetes. Everybody tends to blame that neuropathy on the diabetes.
I would at least look a little beyond that, because that neuropathy, of course, can be related to the long-standing diabetes, but again, given the prevalence of this in the population of African Americans, I think we've got to look, for other causes sometimes. Thank you, and have a wonderful day. I appreciate the opportunity to do it.